Morning, everybody, and thank you for joining us for our very first vertical integration session of 2026, Saving Nephrons in General Practice, presented by Dr. Martin Feddersen. My name is Rochelle. I'm an Education Officer from the Primary Health Network. Before we begin, I'd like to acknowledge the traditional custodians of the lands in which we all live and work on, and pay my respects to Elders past, present, and emerging, and extend that respect to any First Nations people joining today. Just a couple of things before we start. This session today will be recorded. Throughout the presentation, if you have any questions, please pop them in the chat box, and at the end of the session, we'll go through and do a bit of a Q&A. And your feedback is important to us. It helps us provide future educational sessions. So I'll also pop a link and a QR code to the Slido evaluation in the chat towards the end of the session. I'll hand over now to Martin to begin his presentation. Thanks, Martin.
Norris, thank you very much for giving me the opportunity to talk about nephrons. We'll just move on. I'll try and cover most of the questions that I think you may have, but I'm sure there'll be many more in the end. So please, I'll try to finish off on time so we can answer a few questions. So I'll just work my way through. Essentially, for those of you who don't know me, I'm a nephrologist. I'm a private a nephrologist. I work at Gosford Hospital mainly. I did my degrees in San Diego, a medical degree in University of Sydney. Traveled a lot. That's why you'll probably notice my accent's a mixture of different bits. I live on the coast with my family, and any hobbies, anything that helps me avoid work, mostly things in the ocean stuff. So what are we going to talk about? We'll talk about the nephron, what the kidney does. So we'll go through some details of that. Chronic kidney disease, obviously that's what the talk's about, prevalence, diagnosis, when to refer, always the big question. We'll do a case presentation, nephron hacks, and common questions, basically, specifically about drugs and dosages. We'll go through some questions. So my career is based around this structure, which all of you know is the nephron. That's quite sad. Of course, there'd be adrenal glands and the renal arteries and the ureters that we're involved in as well, but it's actually quite incredible what this structure does. There's about 1 million of these in each kidney, plus or minus a couple 100,000, and we lose them as we get older. So we'll talk about age-related decline in GFRs a little bit as well, and where that fits into the picture. So I always tell patients, or any time I give a talk, that the kidney is an organ of homeostasis. So essentially, it creates balance. So it selectively excretes and reabsorbs water, electrolytes, glucose, calcium, salt, amino acids. So it's always looking at finding balance. It regulates your body pH, keeping it quite tightly controlled, that with the lungs as well. It regulates water balance. I put the Michelin Man up there because I tell patients when they're like, oh, I'm peeing more, I'm peeing less. I was like, look, the kidneys have been doing this for millions of years. Generally, if your kidney function is within an acceptable range, it does all the regulation very well. But if it didn't, you would balloon up like the Michelin Man, So another way that the kidneys, do their homeostasis. Blood pressure control, that's via sodium handling, water balance, the renin, aldosterone, angiotensin system, which nephrologists and cardiologists are obsessed with. It activates vitamin D. It regulates bone health through the parathyroid gland as well. Erythropoietin production, and it's funny, even to this very day, when I explain to patients what drug I'm going to be putting them on, even if they're younger, they know Lance Armstrong, who was got caught for doping. At least everyone else was probably doping, but he was the highest profile guy. So Mircera is what we traditionally use as a long-acting agent, but there's other erythropoietin stimulating agents, or ESAs, which is the acronym we traditionally use, that we use as well. And we'll talk about when these things get given, and So just a couple of physiological things. So the kidneys receive 25% of their cardiac output. A lot of people don't know that. Despite it only weighing, 0.5% of the body weight. it filters a tremendous amount of plasma, 60 times per day. And that it does that on that level, it absorbs and excretes, quite actively to be able to find that, homeostasis and that balance. Without the kidneys, we couldn't have left the ocean. Essentially, we're kind of, with the kidneys, we're bringing the ocean with us, so to say. So there's always a historical character you need to put into here. So the reason I put this in, because you would have had patients say, oh, my grandmother had Bright's disease. So Sir Richard Bright in the mid-18th century, so he basically noted that people with edema and foamy urine or dropsy, this was the first routine laboratory test that was created to look at the amount of protein, the presence of protein in the urine. And that picture there of the urine dipstick, probably the cheapest and most powerful nephrology tool of all time. And I don't think that will ever be trumped, because when you do a urine dipstick, and I do that on all my new patients, if there's no blood and there's no protein in the urine, we are less anxious about that than they have a bland urine. So that's always a very powerful tool to kind of distinguish if there's something more aggressive occurring. And I always tell my juniors in the hospital, don't wait to tell me what's in the urine right to the end or have me ask it. Tell me up front, if they have an acute kidney injury and there's blood and protein in the urine. That makes us a bit more concerned about glomerulonephritis. Glomerulonephritis can eat up the kidneys. That's a time pressure of getting a diagnosis and treatment. So the prevalence of chronic kidney disease, 14% of the world population. In Australia, it's 1 in 10. So that's a lot. And we'll talk about who fits into this category. There are only about 500 of us in Australia, apparently. And in the world, it's about 788 million worldwide. So there's a rising trend. So nephrology has come into the spotlight, and we'll talk about why. Generally, it's because we've tagged ourselves onto the cardiologists, and they've got the most money and they've got the highest profile. But now we're kind of edging slowly along, and I'll explain to you why. So there's a rising trend, aging population, more diabetes, hypertension, obesity. It's essentially the obesity pandemic, and the metabolic derangements that occur that are probably driving chronic kidney disease and vascular disease in general. So in Australia, all Australians about, almost 40% diabetes, and then about 27% hypertension. So diabetes and hypertension, the most common cause of chronic kidney disease. The good news about that is that we can do stuff about that. Then there's glomerulonephritis, and there's polycystic kidney disease, these other conditions. And in Aboriginal and Torres Strait Island, as you can see, it's very high. So anyone who has that background really needs to have a kidney screening. So what does this all mean? Less than 5% of people will require kidney replacement therapy. So, out of all the people. So it is low. And that forms of kidney replacement therapy can be either hemodialysis, peritoneal dialysis, or transplant. About 53% are receiving dialysis. Majority is hemodialysis. And then we have other home therapies like peritoneal dialysis, and about 40% of them were functioning kidney transplants. I was actually quite surprised at that ratio. That's not what we're seeing on the Central Coast, probably because of our aging population. We have vast majority of people who are receiving kidney replacement therapy or receiving dialysis. It all has to do with health economics, kidney transplants. If you look at the numbers, inpatient hemodialysis costs about maybe, rough estimate, $100,000 a year. Home therapies cost about $50,000 a year, and a functioning transplant after the first year costs about $10,000. So it's all about, how we can use health laws. And of course, functioning kidney transplant patients can be at home. They can live their life. It's the ideal, and we're replicating the function of the kidney as best we can. Hemodialysis itself, doesn't do it very good. So if someone's kidney function is down to 5%, I always tell patients dialysis is adding maybe another 3% on top of that. So not great. These are the documents that kind of guide things. The main one really is KDIGO, which is kidney disease improving global outcomes. They write the global rule book for kidney medicine, and they need to write it in such a way that it's really translatable around the world because we have different forms of kidney disease, and on top of that, we also have different drugs available depending on how wealthy the country is. But they give you a general guidebook, and then there's a GP Red Book, Kidney Health Australia, and then the CARI guidelines. So why does CKD matter in Australia? As you said, 1 in 10 Australians. The one thing I always tell patients, because they tend to sit in front of me and going, I don't know why I'm here. I feel great. And I'm sure all my GP colleagues has explained to them exactly. But the key word I tell them is that it's a silent disease, like hypertension. And when you say that to patients, they say, oh, when you start having symptoms, I always tell them the horse is already bolted. It's too late. You need to get in early. So it contributes to a large amount of deaths. And the one thing which has brought kidney disease into the spotlight is because it's a cardiovascular risk multiplier. And that's what I was saying, that's brought it into the spotlight a bit more. So there's a threefold increased risk of cardiovascular disease. It's a risk factor like smoking and family history and hypertension. So early intervention reduces the risk of dialysis and cardiovascular events. So definition, it is a very, very broad definition. And so there's always a concern of we overdiagnosing, underdiagnosing, probably a bit overdiagnosing. So you need to have abnormal kidney structure function for 3 months. So if someone has had a low GFR, you repeat that again, in the course of 3 months to see if that remains low. A eGFR of less than 60 mils, you automatically get a diagnosis of chronic kidney disease. There's also other markers, albuminuria, which we'll talk about as well. And they used to be called microalbuminuria, but the powers that be decided micro would make people think it was only a micro problem, but it's really, a moderate problem. So now it's called a moderately increased albuminuria, microalbuminuria, and macroalbuminuria is called severely increased, just to bring a bit more spotlight that it's just not albuminuria. It does have health implications. And then there's urine sediments, imaging, biopsies, all those can be, you can have markers of kidney damage, and they all fall into the category of chronic kidney disease. You've all seen this chart. I just brought this in again so you can kind of see that, the more albumin you have in your urine, the worse the outcome. That is the key marker that we're looking at. And that's why we're obsessed with reducing albumin, because you need patients just do better. So if you look at this chart, we see albumin reduction. The more albumin reduction, the lower the risk of reduction in the risk of kidney failure. So it's an independent predictor of kidney progression, independent risk of cardiovascular. So it's a key treatment target. So we're always wanting to check albumin creatinine ratio. So the question quickly, one of the questions I've had before, albumin creatinine ratio, protein creatinine ratio, which one should order in the community? Albumin creatinine ratio. It's it's for screening, staging cardiovascular risk. Nephrologists will tend to do protein creatinine ratio, if not both at times, because about 50 to 70% of the protein in the urine is albumin, and the rest of it can be other things like light chains, and that's like myeloma or monoclonal gammopathies of renal significance, because you've all heard of MGUS with the monoclonal gammopathy of uncertain significance. So light chains is what we always consider. There's other ways to test. Insulin can be a protein, beta microglobulin. So I would always use ACR in the community. So in primary care, so suspected glomerulonephritis nephrotic syndrome, we start using protein creatinine ratios, or we do at times 24-hour protein collections as well. So how to interpret ACR? So it can be confusing when people talk about albumin creatinine ratios and protein creatinine ratios. So I would probably just stick, as I said, with albumin creatinine ratios. So if you look all the way down here, probably should have put this on top. So the best way to do it, if you have an albumin creatinine ratio of 68, you're just adding a 0 into it. And so that will tell you it's 680 milligrams per day. right? So it's the same with protein creatinine ratio. We just add a 0, and it tells you how much the daily excretion is. So anything normal is 30 milligrams below. Anything moderate increase is 30 to 300. And then you have macroalbuminuria, and those are above 300 milligrams per day as a guide. So you'll have these ACRs that are between 3 and 30. They're not nephrotic, but when you start going above 30, then you may be considering that, man, this may be a nephrotic syndrome or nephrotic range proteinuria. But of course, those readings need to be, if we're saying this nephrotic, it needs to be up about, 2,000, 2,500 milligrams per day. So I hope I haven't confused you. That's just a basic kind of gist about albumin creatinine ratios. Who to screen? Diabetics, always. Patients with hypertension, because we know those are the main risks of kidney disease. Anyone over 60, patients with cardiac disease, Aboriginal and Torres Strait Islander people, family history of kidney disease. So what's the workup? So basically checking the EGFR. You want to do a urine, an albumin creatinine ratio, check their blood pressure, and then, HbA1c lipids, depending on other risk factors. And then the rest of these down here, renal tract ultrasounds, autoimmune scoring spreading, that's more kind of, if you're keen, you're more than welcome to be autoimmune if someone's got, macro or severely increased albuminuria, but generally nephrologists will kind of enter that area there. A renal tract ultrasound is absolutely very reasonable to do in the community. And it depends on how comfortable you are, because sometimes interpreting monoclonal gammopathy is of uncertain significance of a renal significance, even for nephrologists, can be a bit tricky. And, luckily we always can just jump in and do a biopsy if we're very concerned. Blood pressure targets, it's like a moving goalpost. There's guidelines. This is about 4 major societies around the world. But generally in Australia, we kind of say, if you have albuminuria, you should be more aggressive at blood pressure management or a history of cardiovascular disease. And if no albuminuria, 140/90 is not unreasonable. And of course, that's different if you have frail elderly patients. And if they've got albuminuria, we want to use, RASes or ACEs and ARBs. Yeah. ACEs and ARBs, so practical tips. So, acceptable creatinine rise, anything. So if you have a creatinine of 100 and it goes up to 130, that's within the 30% rise. We even tolerate higher readings. But if you start getting 40 to 50% rise in your creatinine, there could be something else going on. And rarely, though we go looking, you can find renal artery stenosis. As in checking potassiums, I generally text between, 2 to 4 weeks generally. The guidelines say it around the 2-week mark, just to make sure the potassium hasn't jumped up. And as a guideline, at what potassium are we more concerned? So studies, when we look at studies at renal protective medication, a potassium of 4.7 and above puts people at greater risk of developing hyperkalemia. So as a bit of a cutoff, but it's also very hard to predict. So if we avoid ACEs and ARBs, you don't use that combination anymore, and you can continue unless there's potassium issues or there's a significant drop in the kidney function. So SGLT2 inhibitors, it's basically swept across many specialties. Apparently, on presentations I've had from people who have been clinical trials here, that in the halls of Cambridge, they basically trial these drugs and saw it does very little to reduce the HbA1c, probably down to about 0.5% HbA1c, so not a great impact, but there was a significant improvement in cardiovascular deaths. And so we had issues with other drugs previously, that pioglitazone and these drugs that, cardiovascular trials weren't done. We noticed that there were some drugs that actually increased patients' mortality. So cardiovascular targets had to be replaced. And so as a result of that, we saw that it had a major impact on cardiac survival and kidney survival as well. So it's a foundational CKD therapy. So as in the impact, untreated CKD, 3 to 5 mils per year reduction treated CKD with a SGLT2 inhibitor. I'll call them Flozins. That's kind of the term they use, dapagliflozin, empagliflozin. So the Flozins, when people treat people with Flozins, you get a significant slowing in the progression of kidney disease, a significant reduction in heart failure and cardiovascular deaths. And there's effective down to GFR 20, but we think it goes down lower. And there's a trial called the life cycle trial that eventually they'll come out. But most nephrologists don't even stop ACEs, ARBs, or Flozins at all. We just keep them going indefinitely unless there is an issue with potassium or something else we're worried about. Side effects, UTIs and thrush, probably more common than we think, although the trials say they're rare. But in my experience, people have dysuria or they'll have thrush. So always make sure that they're aware of that. I don't exclude retrialing this drug in 3 to 6 months. And I explained to them its significant impact on their overall health so that we do trial it. And sometimes when you trial it again, they're fine. There's no need to check. You can basically just put the patient on the drug and walk away. Apparently, if you take the drug, when you leave the pharmacy, by the time you get to the car, it's already had its effect, which is unlike statins, which you need to be on for about 6 to 12 months' time to really get the impact. So it's that immediate, the effect. So there are new PBS criteria. I know this talk has been recorded, so hopefully I never get audited. But we were already putting people on Flozins much earlier, a lot of nephrologists, because we knew from the clinical trials that it had a benefit. So essentially, GFRs of 20 to 45, you don't need any albumin in your urine. You can just put them on the Flozins. So that just came around very recently. And on top of that, down below, GFRs of 45, it used to be up to 75, now it's up to 90 mils. So anyone who has albuminuria, above that level, essentially can be put on to a Flozin. Yeah. So there's other drugs that have come out, Feddersen, you may have heard about, and that's specifically for diabetic kidney disease. And you essentially, you need to have patients on ACEs and ARBs and may or may not need to be on a Flozin. It reduces the progression of kidney disease, cardiovascular events. It has a low effect in potassium, so we don't worry so much about hyperkalemia. It has a less hypertensive effect. There's no gynecomastia because you're not blocking the, you're not affecting estrogen and testosterone receptors. And it has a greater antiproteinuric effect. So we generally use this in diabetics where we're not getting that albumin reduction that we're hoping for. So this is just a case, just a case that you may see. A 62-year-old male, a type 2 diabetic, glycemic control, not so great, GFR of 48 mils. They've got urine ACR of 120. So as you said, you just add 0. So essentially that's 1,200 milligrams per day. So that's significant. Blood pressure of 140/80. They're on metformin and on perindopril. And what would you do if this was more interactive and I know how to use the technology? I would ask, I guess I could just ask if anyone wants to shout anything on this. Is there anything that they think needs to be done? If not, I can just move on to the next slide. So if there are any other treatments that you'll put them on, or how would you approach this? And I've left further investigations out, just because I think if you're concerned, patients can be referred to nephrologists for more, more detailed investigations. So any ideas at all? What would happen next? What would you add?
So would we add the SGLT2?
For sure, yeah. You could probably crack your perindopril maybe as well. So, it's always, finding out, I tell patients antihypertensives are not all made equally. Some of them are better at doing something. So anything that's an anti-proteinuric, we can crank up, but absolutely. So maximize your ACE dose if you can tolerate it. That's probably the first thing that I would do, would crank it up to its full dose. And as was said, you can add a Flozin. Now, Flozins have an effect where they have a caloric effect. So you actually remove some potassium. So there's a bit of a potassium lowering effect. It also can reduce the blood pressure a little bit. So you want to target the blood pressure a little bit more tightly. You want to add a statin, and it's up there. So all patients really with a diagnosis of kidney disease should be put onto a statin. And that's disregard of what their cholesterol level is. Now, some people have very low cholesterols. We don't know exactly. If they're really low, sometimes we just reduce the statins. Then, of course, there are the new GLP-1 agonists. So that's another addition. And the one thing we don't often do is actually really push lifestyle issues. And I try to push that as often as I can. Just simple things like walking, and if they're more interested, cardiovascular work. And then, there's a lot of evidence around resistance training too, and weights. And if there's no improvement in the albuminuria and the kidneys declining, then a referral can be made. Advanced, more like another diabetic patient. Apparently, nephrologists see more diabetics than endocrinologists, statistically speaking. But we still involve our endocrine colleagues, to get that HbA1c at target. So 71-year-old, HbA1c looks to be pretty well controlled. GFR quite low. Albumin creatinine ratio 85, so added 850 milligrams, so quite high. ACEs on an ACE and SGLT. So in this situation, you could consider finerenone, check the potassium, and refer to us. So when to refer to a nephrologist? So the first thing I'm going to say is, as a specialty, we are there at your service, essentially. 95% of our work has to do with supporting, general practitioners in the community. So you should always feel free to pick up the phone and talk to us at any point in time. I'm surprised I don't get more calls. Always happy to speak. But these are referrals. These are kind of what I call kind of red line. Like at this point in time, they really should be referred. And then there's a range that is fairly gray. So GFR is less than 30, absolutely. Even if it's stable, they should just be sent through. A sustained decline greater than 5 mils per year. So if you're watching things, I tell patients we don't look at individual GFR or creatinine readings. There's about a 10 to 20% variability depending on the time of year and the labs. But if you see, we always say trends are our friends. So if you're seeing a consistent decline, they should be referred. ACRs of greater than 30 milligrams, so really when we're looking at, a macroalbuminuria, they definitely should be referred. But of course, if they have microalbuminuria and you're not entirely clear and you've been managing it and it persists, they can be referred as well. Resistant hypertension, that's kind of a, gray area there. You need to be on 3 antihypertensives. One of them needs to be a diuretic but resistant or troublesome hypertensive, we all have those patients that, are special and basically have an allergy to everything, any drug you put with them. Those ones can also be referred. But resistant hypertension up there, if you're uncertain of the diagnosis and you're really not sure, obviously, and, George and I was speaking before everyone got on, earlier was always better. An earlier referral and getting an early, and if it's a bit too early, doesn't matter, no harm done. At least we can get a bit of a gauge, we can talk to people, and at the very least, if we don't have anything to change in the management because they've had an excellent GP who has managed everything, at least we can reassure them and have a bit of a plan to follow up with them and then refer them back to you guys. So referrals, whenever you like, there's always something we can add. And of course, always pick up the phone. But those at the top are probably the ones where I'd say for sure they should be referred. Drugs and chronic kidney disease. So, metformin is always a question, and that's also a bit of a moving goalpost. When do we stop? When do we start? There are different, practices between nephrologists, but there was a very good study that came out not long ago that basically said we stopped metformin way too early. And the risk of metformin-associated lactic acidosis, I've seen that maybe once or twice in my career, so very rare. So I would say, if we maintain a little bit metformin, it's a treat drug. I tell patients they may have some anti-aging properties to it that have been researched. It can help people lose weight, definitely has some cardiovascular effect, mortality improvement. So, but definitely an improved all-cause mortality when we leave people on this. So I would say GFRs of 20 to 45, 1,000 milligrams, and otherwise 2,000 milligrams. So we used to stop it at 30, but really we think in general it can go down to 20, unless someone's got severe diarrheal illness, then they should have that stopped. Trimethoprim, probably one of the most common causes, of a drop in the GFR and hyperkalemia. So it falsely raises the creatinine. So it's not nephrotoxic. It just stops the secretion of creatinine in the proximal tubule. So that can rise, and it can, when you calculate the eGFR, it can look like it's worse. So no, but the issue that can occur is it can cause hyperkalemia in some patients. So in patients with GFR of 20 mils per minute, you want to be cautious. And the quickest question I ask patients, and it's one of the only drugs that's a daily tablet, I say, will you want an antibiotic that you're taking on a daily basis? And if they say yes, then I tell them, I know what's caused this. Osteoporosis, another question, bisphosphonates generally are good. GFR is less than 30 mils. I would say you can probably use Prolia. Prolia-induced hypocalcemia, we probably see that, it probably occurs more often than we think without us really knowing. And I generally say, if the GFR is less than 30, you can load them, double their calcium and or vitamin D for 2 weeks prior and continue that for another 2 weeks afterward. Studies show that it probably, low calcium probably goes for about 4 weeks afterward, but I find this works. It's a simple, straightforward kind of bit of a plan. When it comes to rechecking bloods, guidelines do say you should recheck bloods week 1, week 2, week 4. We're all very busy. So I think this is a practical guideline. I always tell people if you've got oral tingling, that you should contact you and get a blood test done. As in checking the blood test, I don't think it's unreasonable 2 weeks after to just check the calcium to make sure it's okay. And when it comes to renal dosing, there's tons of them. And I always find it humorous when people call me asking me for dosages, and I tell them I have to look this stuff up as well. So luckily we have a great renal pharmacist at the hospital who always helps us out. But I would go with renal dosing guidelines. And of course, there are particular patients and particular drugs where the dosages, sometimes we need to have them on the drug. And so we push the limits a little bit. So just a couple of things. NSAIDs, also a common question. I never say no to anti-inflammatories. I think disregarding them completely is unfair to patients who struggle with osteoarthritis. We always want their kidneys to be healthy, but the truth is that you're dealing with, a whole organism. And if it keeps them moving, I would say that has a greater, more powerful effect on their overall health and their mental health than worrying about a transient drop in their GFR. So I just educate patients and say, I won't say no, but NSAIDs will cause your kidney function to transiently drop. It may give you a bit of leg swelling. So I would say I would take it maybe once, at most twice a week. If you're planning on going for a walk and you want to see people, you can take 2 ibuprofen in the morning and get yourself moving. So it's a gray area. I never say no entirely. Stroke restrictions, a bit of evidence, and I have a list right at the end of kind of like, evidence-based, high impact type stuff. to preserve the kidney. Vaccinations, lifestyle, we talked about that. So just common questions. I know I'm running kind of low on time. So, GFR 58, is this CKD? Do I refer them? Do I have to be worried? Common question. So if it's maintained over 3 months, it does fulfill the criteria of chronic kidney disease. Of course, we have these muscular, young, healthy people. That's a separate presentation on doing cystatin C. I'm happy to answer some questions or doing more accurate measurements, so they don't get that diagnosis of chronic kidney disease. Urine ACR, if they've got persistent microalbuminuria between 3 and 300 milligrams per millimole, that does fulfill the criteria of chronic kidney disease. And then they're the aged elderly patients. So at the age of 40, most of us will have, I tell patients, about 80 to 100% kidney function. As I said, you were born with about, 1 million nephrons, maybe less or maybe more. So at the age of 80, eGFRs can range between 45 and 65 mils per minute. So it's quite a big range. So it's an age-related nephron loss. Is it still considered CKD? At this point in time, yes, it is. If it's less than 60, it is. There's always big debates, at meetings, if the GFR is age-related, is it actually a disease? I guess the greater question is aging a disease, and the World Health Organization hasn't classified that as a disease. But the truth is that I tell most patients, if people didn't age, I'd be out of a job. So there's no doubt that aging is a disease process. So age-adjusted definitions, are always under debate. So RASI management, put them on it. I said if their potassium is at 4.7 or higher, there's a greater risk. You need to watch for hyperkalemia. What level does a nephrologist, really is more concerned? For me, it's probably around 6.1, 6.2. Anything above 6.2 millimoles per liter is when I kind of say, look, I probably need to go to the emergency department. If they have a history of cardiac disease, it probably is a little bit earlier than that. But most importantly, I just repeat the blood tests if I can. We talked about key points, as in creatinine rises. Microscopic hematuria, always so common. Is it a cancer? Is it a nephropathy? And there's no straight answer, but first thing you do is you repeat, make sure it's not a cystitis. You check the urine for any presence of albumin or protein, and if there's any of that, maybe there is a nephropathy. And if there's persistent blood in the urine, preserved kidney function, urine is otherwise no protein, then you really need to consider doing urine cytologies and a CT-IVP to look for urothelial cancer. Anyone over the age of 40, there's multiple guidelines around the world. They suggest different things. Definitely a smoker, you need to be considering that. And then if there is no finding on the urine cytology and CT-IVP, they probably should have a cystoscopy. Hyperkalemia approach, repeat the test, review the drugs. And when it comes to dietary, in Australia, it's potatoes, tomatoes, bananas, and avocado. So those are probably the biggest hitters. And if their potassium's high, you can always ask them, and it will be one of those culprits that they have. And I tell people, you don't need to stop eating it, just don't eat it every day. And there's potassium binders, but they generally, even the new ones, it's like you're drinking chalk. So blood pressure targets, we talked a lot, albumin lower, generally 140/90. And then there's those elderly patients. Some of them, I don't even worry about the blood pressure, because if blood pressure is below 150, they get dizzy and they're frail. And so, that's also a little bit nuanced. And I think the most important thing is if you have an elderly patient with a blood pressure of 180 in front of you, or even 200, don't panic. Just get them to stand up, do a blood pressure when they're standing, get them to do it in the community. Hypertensive crises in my years as working as a blood pressure specialist is exceedingly rare. So no reason to panic. Just check again in the community. Of course, if they have chest pain, they look sick, and you're concerned, they can be sent up to the emergency department. All right, anemia and CKD, just a quick one. When to start iron, when to start the erythropoietin stimulating agent. So basically check the iron levels. If they're iron deficient, replace that. You can do oral or IV, and then investigating their low iron levels with maybe scopes. And when it comes to an erythropoietin stimulating agent, definitely GFR is below, generally GFR is below 30, and the hemoglobin is below 100. So we usually keep it between 100 and 115. So hemoglobins of 106, we don't start, we have patients don't really have any clinical improvement. And in fact, I'll probably say, sadly, about 20% of patients with GFR of hemoglobins at 90, when I improve that, do they feel any better? Sometimes when people get their initial dose, they feel a little bit better. So, those targets are different with people in nursing homes, and they're basically bedbound or they're sitting. They probably only need a hemoglobin of 80 or 85 grams. When it comes to dialysis and planning, it's a very nuanced area. A number doesn't mean you need to be on dialysis. It's usually symptom-based. Creating dialysis access takes sometimes a long time, a functioning fistula, so that's why it's always good earlier. And of course, we have a non-dialysis pathway, and we have a great program at Gosford Hospital where we have really well-trained nurses, and we had our 10-year anniversary of supportive care. And so we have a lot of people on a non-dialysis pathway who live many years and not having to worry about kidney replacement therapy, which is really more or less a young person's game. So contrast safety, another question, contrast-induced nephropathy, does it exist? Debatable. I would say in general, I never just kind of say patients can go ahead and have it. I always look. I would say if you're in doubt, a liter normal saline pre-contrast is not unreasonable. Metabolic acidosis, that's also a bit contentious. Do we replace it? Guidelines put a little bit less emphasis on bicarbonate replacement because you're giving them a lot of salt with a very salty big tablet. But if they're persistently below 22, there may be some benefits with slowing the progression of kidney disease. So, that is limited, or keeping their bones stronger. Unexplained edema. If the albumin creatinine ratio is above 300 milligrams, and the albumin is low, then maybe the kidneys are involved. But of course, the vast majority of our 70-year-old patients is probably lymphedema, or they've just got old legs and old blood vessels. But of course, cardiac, renal, and hepatic causes maybe need to be excluded. Cysts, another question, really. We see a lot of cysts. Cysts are quite common at the age of 40. 2F, and of course, unfortunately, a lot of the new pop-up radiology companies are not really giving us Bosniak classifications. They were just telling us, but there's complex features and thin septa. There's about a 5 to 10% malignancy risk. That should probably be repeated in 6 months' time. Most of them will be just simple cysts, and if you're concerned, they can be referred to us or a urologist. So what actually moves the needle most in preserving the nephron? Blood pressure, diabetes control, lower salt. I tell people anything that's packaged or cans, do your best to avoid. You can eat as much whole foods as you want. Smoking cessation, weight control. We talked about drugs. Plant-based diet, fish, probably some evidence. Protein moderation, it's also very gray. And exercise is a major cardiovascular benefit. So, all right, I think those are probably the main things. We still got another 15 minutes. Hopefully, I was able to cover most of the questions you have, but I'm happy to. Let me just see how I go off of this.
Awesome. Thank you so much, Martin. That was an amazing, initially the overview and then all those little gems that I've been writing down. So thank you so much. We do have some questions in the chat, and then we might have some people put their hands up if they like. So there was a question, how do you manage worsening eGFR and creatinine on commencing of the SGLT2s?
Look, generally ignore. So I tell people, and it's funny you get this question. It took me a few years to find out the right way to answer people, because they're like, why are you putting me on a drug that's making my kidney function worse? What's the point of that? So I tell them, the drugs is making your kidneys work less hard so they last longer. So that's the way I explain it. So a drop in the GFR with an SGLT2 inhibitor is completely acceptable. I'd repeat that again in about, as I said, you can just put people on it and leave. That drop is completely acceptable.
Yep. And should we be checking calcium levels before every Prolia injection?
Potassium in Prolia or calcium?
Oh, sorry, calcium.
Calcium. Look, generally don't need to. We traditionally do calciums quite regularly with a lot of our patients. I think if the GFR is less than 20 and you're worried about hypocalcemia, I don't think it's unreasonable to check the calcium. Load them up with vitamin D and calcium. So if they're already on Oscillin and calcium, I'll just double the dose for 2 weeks prior, and as I said, continue it for another 2 weeks afterwards. And then if you're concerned in the select patients with the GFR is low, I'd say at 2 weeks after that, you can probably check the calcium again. Yeah.
Yeah. And then one of the doctors said that she avoids olmesartan because Dr. Rogers said it was one said it was renal toxic. Is that true? and to lead on for that, can you start an ARB first instead of an ACE, or it's still preference to start the ACE first?
Yeah, well, I would never cross my mentor and colleague, Simon Roger, now retired, of course. I'd always support what he says, but there was a black box warning specifically on olmesartan that, maybe there's some concerns. Generally, most nephrologists wouldn't necessarily change your ARB from one to another. So I generally am quite happy to continue on olmesartan. Now, Simon may give me a call soon if he hears this talk. When it comes to ACEs and ARBs, so, ACE inhibitors are the original flavor. So we know that it stops the process further higher up. And so you can get this cough, and that is thought to be due to the bradykinin that it gets, that you have a higher amount of. And so that is thought to help the blood vessels. So when it comes to the drug that we should be putting people on, Arasi, ACE inhibitors are probably the first go, I would say. ARBs are much more convenient, though. You put people on it, it's less likely to have a cough because about 10% of patients, if not more, get an ACE inhibitor-induced cough. But I think we need to be brave, and we need to put people on ACE inhibitors as a first protocol, and then ARBs after. And if there's a choice, we always want longer-acting drugs, and the longest-acting ARB is a telmisartan or Mycardis. Yeah.
And what about the patient, especially other patients that have really low blood pressure? Can we go straight to an SGLT2 rather than an ACE or an ARB, or you prefer us to try a little tiny smidgen of the ACE first? I've got a few patients that, their blood pressure is under 100 and you're like, oh.
Look, I would always say it's not unreasonable. I use Ramipril.
Yeah.
It's not unusual. It's not. It's reasonable to try that as the first protocol because that is a cheaper drug. But if you're concerned that the blood pressure is low and there's other indications that they're diabetic and they've got heart disease and you don't think they tolerate it, it's not unreasonable to put them on Aflosan right away. Yeah.
Yeah, cool. And then Diana asked, similar along the lines of low blood pressure with dysautonomia and low blood pressure, is it okay to advise dietary salt for symptom control with those with renal failure?
Oh, sorry, I didn't hear that. Sorry, Georgia.
So with patients with dysautonomia and low blood pressure, is it okay to advise dietary salt for them for symptom control?
Is it okay to use
dietary salt, so like hydrolyzed?
Yeah, that's okay. If they have dysautonomia, you mean if their blood pressure, they got an issue with hypotension? Specifically, if they, maybe I'm saying like diabetics who really have fluctuating blood pressures. There are some people who have just a low blood pressure, and those patients we do have more salt for sure. Or we use fluorocortisone, which is basically an artificial version of aldosterone to try to bring the blood pressure up. So I hope that answers the question. Yeah.
Good. And Subhashi, did you want to speak and ask your question regarding a patient? And we just need to be careful, I suppose, when we discuss patients to maybe make them not to because it's recorded, so we want to make sure we don't. You need to de-identify them. So Subhashi, did you want to mention Your example?
Yes, I have a 64-year-old male with hypertension, type 2 diabetes, obstructive sleep apnea, and controlled gout on allopurinol 300 milligrams. His EGFR and creatinine is normal, but his UACR fluctuates between 30 and 60 all the time. And he's on telmisartan, allopurinol, Diabex, Crestor, and Jardiance. So is there anything else? And the blood pressure is well controlled. The diabetes is very well controlled.
Yeah, that is always, thanks, Sebastian. It's a great question. And there's always those people where you put them on all the appropriate medication, everything's good, and their urine ACR just persists. Why that happens, we don't know. There's just some people are just made like that. So I would say, the next protocol, probably depending on the blood pressure effect and how low their blood pressure is, I would say a Flozin's not unreasonable, Samashi, as the next thing. If they're not on that already,
actually, he's on Ozempic as well.
He's on Ozempic as well. All right.
Yes.
So is he on Forxiga or Jardiance as well?
Yes, he's on Jardiance, yes.
Good. Well, you've done. So the next protocol really, if you're going to go next level, is to consider something like finerenone. And, someone who's diabetic, do they have diabetic kidney disease? Presumably, if someone has blood diabetes for greater than 5 to 10 years, they've probably got, if you did a biopsy, they've got diabetic kidney disease. So I would say finerenone 10 milligrams be a next protocol. And we know that doesn't drop the blood pressure very much, doesn't affect the potassium. So I would try that, start them on 10 milligrams. I would still check the potassium in about 2 to 4 weeks' time and just see how they tolerate it. And if they do, you can bump that up to 20 milligrams. Yeah. And
he does have a family history of chronic kidney disease, where the father had to go on dialysis.
Yeah, okay. And that's one of those things when it comes to genetics and kidneys. We know diabetes is a case, and we'll probably know it's, genetics are in kidney medicines really in its infancy. So there's probably people who are more prone to kidney disease, and there's a family history. So for sure. But if you ask them long enough, you'll probably find out that their family members probably have diabetes, and that's probably the one thing that's affected the kidneys. And I always joke with my colleagues that my kidneys are perfectly fine. Everyone else is ruining them. The hematologists are doing things to my kidneys, the cardiologists, the endocrinologists. So, but yeah, I think finerenone would probably be the next protocol. Yeah.
Okay, thank you.
I've just got one more question. It might be an obvious one. So with the, occasional patient that needs some anti-inflammatories on their golf days, I assume short-acting like ibuprofen is better than your longer-acting like your Celebrex? Or
doesn't. Yeah. It's a bit more academic. No one knows exactly. The thought of anti-inflammatory effect on kidney disease and on the heart, you need to be on 5,000-10,000 doses, like fairly high doses for a long period of time. So short doses so they can get out and golfing. It can be either Mobic, it can be a COX-2, or, we don't know exactly. Of course, you would say on not having it and using Panadol, but I've not met a patient who says Panadol really helps with osteoarthritis. So anti-inflammatories are so effective. And I think we used to just exclude them. And then we started using lots of opiates. And what's happened is that now we're shifting away from opiate use and all the dramas and the mortality effect that we have on there. And we're shifting back to anti-inflammatories and just using it cautiously and responsibly. And it's just about patient education. And when you let patients know that, they realize, yeah, okay, I will just take it on these days. I won't take it too often. Yeah.
Fantastic. I think that's all the questions for now. So thank you so much, Martin. And if your phone was quiet from GPs, I think that might be about to change. But that was fabulous. So thank you so much. And I'll hand over to Rochelle for the wrap up, and we'll see you in 2 weeks' time. We've got, is it James Panetta in 2 weeks? I think it is. So thanks again, Martin.
Our friend James. Yeah.
Our friend James, yes.
Thanks, Georgia. And a big thank you to everyone for joining us today, and a huge thank you to Martin for taking the time to present this morning. Just a reminder, I've popped the link in the chat for the evaluation. If you can take a moment to do that before you leave, that would be great. I've also popped in some photos of the health pathway slides that our team has provided as well. So they're in there as well if you want to have a look at those. Thank you very much and enjoy your day.
Thank you very much, and call your specialist if you have questions.
Thank you. Thanks, Martin.
Thanks, everybody. We'll
Thank
see you in 2 weeks.
Bye.